Premature atrial contractions. Premature atrial contractions, PACS, are defined as beats of atrial origin that come earlier than the expected normal sinus beats. They are also called atrial extrasystoles, meaning that their site of origin is outside the sinus node, extrasinus. Causes of PACS. PACS are extremely common at any age, both in normal individuals and in patients. Systemic causes include endogenous diseases, for example, febrile illnesses, thyrotoxicosis, emotional stress, and exogenous causes, for example, alcohol, tobacco, caffeine, and digitalis. Cardiac causes include pericarditis, myocarditis, ischemia, and heart failure. PACS are characterized by the following. P-wave occurs earlier than the expected sinus impulse. Subtle change in the vector of the early P-wave. PR interval of the conducted PAC is usually normal or minimally prolonged. Marked prolongation of the PR interval may indicate the presence of dual AV node physiology. P on T. The premature P-wave may be superimposed on the T-wave of the preceding sinus impulse. Recognition of the P-wave, distorting the previous T-wave, may be the only clue to diagnose PAC with aberrant intraventricular conduction, and differentiate it from PVC. If the P-wave distorting the previous T-wave is blocked, it will be followed by a pause, but obviously without QRS. The pause after PAC. Since the PAC commonly invades and resets the sinus node, stimulates it ahead of time, the rule is that the pause is less than compensatory, that is, the sum of the coupling interval, CI, before the PAC plus the return interval, RI, or the pause after the PAC, is less than 2 cycles. Compensatory pauses, that is the sum of CI plus RI equals 2 cycles, may occur because of failure to invade and reset the sinus node. Longer than compensatory pauses may occur, due to overdrive suppression of the sinus node, delaying its return interval. Pause with no QRS following the PAC, is due to failure of conduction of the PAC to the ventricles, blocked PAC. In most cases, the sinus node is reset by the PAC, its next impulse will come earlier than expected, and the pause is less than compensatory. In this case, the pause after PAC is less than compensatory, that is, the sum of the coupling interval before the PAC and the return interval or the pause after the PAC, is less than 2 cycles. If the sinus node is not reset by the premature beat, the next sinus impulse, S, and the P-wave will come in time, and the post-extrasystolic pause is compensatory. In this case, the pause after PAC is compensatory, that is the sum of CI plus RI equals 2 cycles. In this case, a blocked PAC is seen, with its P-wave superimposed on the preceding T-wave. The pause is compensatory, that is the sum of CI plus RI equals 2 cycles. Normally, the QRS of the PAC is narrow, because it conducts in the His-Purkinje system. In case of aberrant intraventricular conduction of the PAC, the QRS complex is wide, raising the possibility of ventricular, rather than supraventricular origin. PAC conducted with bundle branch block or fascicular block. Transient block of the PAC in any of the bundle branches or fascicles may occur, including right bundle branch block, left bundle branch block, left anterior fascicular block, left posterior fascicular block, left septal or median fascicular block. Differentiation between PAC with aberration and PVC. Aberration is strongly favored over ventricular ectopy, PVC, if the following 3 criteria are found together. 1. A long short cycle sequence. 2. An initial QRS vector, in the wide QRS, similar or identical to that of the narrow QRS complexes. 3. Right bundle branch block pattern of the wide QRS. Ventricular origin, PVC, is likely in the presence of any of the following. 1. Absence of a long short cycle sequence. 2. Fully compensatory pause after the wide QRS. 3. Fixed coupling interval between the normal and the wide QRS complexes. The best differentiation, however, between PVC and PAC with aberration is obtained by careful analysis of the wide QRS configuration. Typical patterns of right bundle branch block, or left bundle branch block, is almost always diagnostic of supraventricular beats conducted with aberration. Atypical right or left bundle branch block patterns strongly favor ventricular origin. This same rule is primarily used for differentiation between supraventricular tachycardia with aberration and ventricular tachycardia, but it applies for isolated premature beats as well. Typical RBBB pattern is mainly identified by 1. RSR', with R' taller than R, in V1, and 2. Tall R with deep wide S in V6. Atypical RBBB patterns include in V1, RR', with R taller than R', or monophasic R, or QR pattern, and or in V6, small r deep S, Rs, or QS, R wave is absent, or monophasic R, S wave is absent. Typical LBBB pattern is mainly identified by small r with deep S in V1, and tall wide R in V6. Atypical LBBB patterns include in V1, marked widening of QRS with any of the following: R wave duration greater than 30 millisecond. Interval from the start of R to the nadir of S greater than 60 millisecond. Or the presence of a notch on the downstroke of S. N/or. In V6, the presence of any Q wave, whether QR or QS complex. Thank you.